And one point, when we observe when he do the wrist extension, there's some ulnar deviation. Do you think we need to do
FCU?
Yeah.
Yeah, you can do the FCU.
Okay.
Yeah.
Yeah.
You'll have enough anyway. So with the suggested doses that I have, we would have used the maximum of 50 units.
Okay.
So we can make the government happy.
Okay.
I'm learning about the government here. See, the thumb, if it's becoming a problem, it's tight right now, but when I asked him to grab the bottle and do some other things, it's not functionally limiting. Because remember, this is his primary movement right now. So I will want him to practice using the other fingers, and if the thumb is becoming problematic, that's the only time I will inject the FPL. If I were to inject the FPL now, flexor pollicis longus, 10 units. Okay, if this were true spasticity, I would have used higher doses, but we're not treating pure spasticity here. It's more like what we call spastic dystonia. My approach to the flexor pollicis longus is like this. I draw an imaginary line between the distal wrist crease and the elbow crease. Somewhere in the midline, I palpate the radius, and it's just medial to the radius. So you can go lower, but the motor point is right here in the middle. Good luck. No, I think you'll be able to use that better. Yeah. 谢谢. Yeah. Okay. Good.
Excuse me. I am treating a surgeon for years. He got the so-called right cramp for the right index finger, and it disturbed him a lot because he's a surgeon. He needed to do a surgery. Yeah. So I use electrical stimulator to locate the fascicle for the right index finger. Yeah. And do you have any recommend for the dilution and the speed, the push rate? I mean, you need to
what?
When you inject, you inject slow or fast to
of
confine.
The injection?
Yeah.
What is his problem? Is it the DIP or the PIP? How does the dystonia look like?
Okay, actually the PIP.
Oh, the PIP.
So I always inject the FDS.
Yeah. So for the sake of his patients that he will operate on, we need to treat this this surgeon well. Electrical stimulation, I will use a concentrated solution. The reason is that we don't want it, if there is no problem in the other fingers, then we don't want it to spread. We don't want him to drop his scalpel because of the weakness. So if this is all what you want to inject, and depending on the severity, you can use a dose as low as 10 units to higher. So I would start low, and then based on this response, I will go higher. So just do a very good motor point localization. Don't even inject until you're able to get a good contraction with 1 milliampere or less of the current. In addition to that, is his wrist going like this as well? Because it's typically, even though the most obvious is the finger, usually there's a wrist abnormality. So assess the wrist as well.
Okay.
He's having trouble writing?
No. Yeah, sometimes.
Yeah. And watch the thumb, because he might be going like this.
Okay.
But use a concentrated one. You don't want it to spread and weaken the other finger flexor muscles.
And when you inject, you inject slowly or fast?
In this case, I will inject slowly, because if you inject fast, the solution will go like this. If you inject slowly, it will only stay very close to the needle.
Okay, thank you.
Yep. By the way, that's another factor that we don't consider, is the velocity of injection. I suspect that the velocity also has some effect on how much of the motor end plates will be reached by the drug. It's just going to be hard to standardize it.
Professor Francisco, ladies and gentlemen, I will present 3 cases. First one is this patient. He's 28 years old male. He has a motorcycle accident in 2006, and he's subdural hemorrhage over left frontal parietal area. And he received craniotomy for removing hematoma. And then so he received a rehabilitation program since then. Now his medication is baclofen 10 milligram TID. So we see his problem list. Now he has a problem over right hand, its tightness. So we prescribe anti-spastic aspirin. Besides, he also had right upper limb clumsy and impaired breast strength. And he also, due to the right upper limb and the low limb spasticity, so result poor endurance. So he ambulation with right FO, but he has the equinovarus deformity. So now our rehabilitation goal is to decrease upper and lower limb spasticity and improve dynamic balance and correct abnormal gait pattern and increase the hand fine motor function. Because he's a chef, so he won't go back to work. So he very focused on his hand function, but he also had the abnormal gait. So we want Professor Francisco give us recommendation.
Okay, how are you? Are you right-handed? Is he right-handed or left-handed? Right-handed. Okay, let's start with the gait first. Just a second. Just a second. Oh, I always want to see the knee. Okay. Okay. Has he received injection before? Because his hand is very loose. Okay. Okay. Just take a seat. Then I want you to go like this. Can't? Okay, now can you try doing it now? Push down, push down, push, push. No, very little, no active movement. He's pushing from here. Let's see how it is with the knee flexed. Push down. Yeah, he's got some. Now, bring your foot up. No movement at all. With the knee extended, limited range of motion. He's got low amplitude clonus. With the knee flexed, easier to range, so the gastrocnemius is tight. But you know what? I'm not sure plasticity. I think it's more soft tissue tightness. It doesn't have that quality that got worse as I range the ankle. I think this is more soft tissue tightness that will benefit from serial casting or stretching. Can you stand up and walk again? And you can see, compared to the other patients that we saw earlier today, look at how he flings this. This is more because of weakness. The foot drop here is more because of weakness. If there's any muscle that may be tight here, it's that big toe flexor. Okay, take a seat. Now, do this. Let's practice with your first. Practice here. Let's do. Bend. Go like that. Okay. Okay, let's do it here. Okay. I'm using my hands as sensors here. As he was trying to struggle with bending his knee, I could barely feel any contraction in the hamstring. When I'm feeling the contraction is in the quadriceps, then the rectus femoris. So he may have two problems here, weakness and inappropriate contraction of the quadriceps mechanism. So this is interesting. Today we're seeing different manifestations of the upper motor neuron syndrome. We saw true spasticity with the first gentleman that we saw. And then we saw spastic dystonia in the hand of that patient we just saw. And now we have the inappropriate contraction. But the underlying problem of all three patients we've seen so far is weakness. And I think in this case, weakness is the most prominent. I don't think that injecting Botox to the distal lower limb will make any difference. What may be helped is the injecting the quadriceps because it's co-contracting, and that might normalize some of the recurvatum that he has. Does he have a brace, an ankle foot orthosis? Yeah, but he has one. Okay, and have you seen him walk using his brace? How come?
Because he don't like it. He think he can walk.
Oh, okay. Yeah, because I was curious to see if the brace corrects the ankle plantar flexion, the foot drop, it may have an effect on the knee. But regardless, I have a strong feeling that the rectus femoris and the quadriceps mechanism is inappropriately contracting. So since it's not really that spastic, if I were to inject the rectus femoris, I will use a dose no higher than 100 units. And then maybe 75 units to the vastus medialis, 75 units to the vastus lateralis, and see how that will work. Okay, but strengthening of the pelvis is very important as well in this case. I'm not sure if we can do any strengthening of his lower limbs because he doesn't have the movement there. Can you stand up here and face this way? Or turn around and face me? Yeah. Some more, face me. Some more. Turn around. No, Okay, you don't even have to touch him. What is different? Just a second. Let's make it fair to everyone. Move a little bit this way. Bring your foot together. Perfect, perfect, perfect. Okay, what's different there? Atrophy. So perhaps it's immobilization atrophy. It's tight. The muscle is tight. It's not spastic. Part of the problem he has is the weakness. It's atrophied here. So I'm not really convinced that the foot drop is because of ankle plantar flexor spasticity. It's because of ankle plantar flexor and dorsiflexion weakness. If you want to inject the toes, if it's causing him, he may sit down. He goes like this, the big toe. If it's not causing any problems, such as pain when during the stance phase, when he pushes off, I'm not even going to inject it. Remember, not every tight muscle needs to be injected. You only inject with Botox if it's causing a problem. What might be causing the problem is the quadriceps mechanism because we want to avoid recurvatum. He's a young guy. He's 28 years old. He's someone that will walk for a very long time. And if you're not going to change the biomechanics of his walking, if you're going into recurvatum all the time, in 15, 20 years, he will have knee injury for sure. I've seen patients with posterior cruciate ligament tear because of the violent general recurvatum. So the joint may be normal, but the forces that he's putting on the joint is abnormal. So the goal is to prevent complications later on. Now the hand, the chef needs that to cook. I noticed that when he was walking, his hand is pretty relaxed. Okay? Are you able to, no, just relax, just relax. Can you move this? Go like this. Squeeze. I'm not feeling any movement, but to give him the benefit of the doubt, it's the thumb that's flexing. The finger's not flexing. Now he is. Okay. But look at the effort he had to do in order to do that. I'm not even sure if he was able to actively do it. I think when he contracts this way, there's a synergistic movement distally. To give him the benefit of the doubt, same thing, put the EMG and the finger flexors and the finger extensors and study the recruitment pattern or the inappropriate co-contraction. The thumb may be problematic. He has a tendency to go like this. The finger flexors are a bit tight. The Ashworth score is about 1 right now. The thumb flexor has an Ashworth score of 2. So I would recommend, in this case, injecting the flexor digitorum superficialis to put him in a, you said that he's not tolerating the brace?
Yeah.
He has a brace? Okay. And then the flexor pollicis longus, and in this case, possibly the flexor pollicis brevis to put it in a good position. Now, sadly, in terms of recovery of movement, I'm not that optimistic. The reason is that there's no active movement that I can feel or I can appreciate right now. But do the EMG and see if there's something there. My recommendation to inject the thumb muscle and the finger flexor muscles is more for promoting good position within the splint and to prevent any contractures. Very tight as well here. Are they having any trouble cleaning the underarm or putting his shirt on? No. He's tight in the pectoralis muscle. Can you stand up? Just stand up. Slightly tight in the pectoralis muscle, but if it's not causing any problem, I'm not going to inject it. The shoulder internals, look at this. I'll stay behind you, okay? See the difference? He's tight in the internal rotator in the shoulder. Do we need to treat it? I don't think so. It's not causing any problems right now. However, if his shoulder is rounded up like this and he's walking this way, then I may treat the shoulder because I want to open up the trunk. If the internal rotators and the pectoralis major muscles are tight, there's a tendency to round the shoulder this way. I would prefer that the trunk be open this way, not only for good posture, but I want the lungs to expand well as well. When you go like this, the rib cage collapses as well. So it may not be an issue for him because he's 28 years old, but if you have an older person with some respiratory problems already, would like them to have enough room in the rib cage for lung expansion. So right now, I'm not even going to recommend injecting that. The ones that I would recommend are the fingers and the thumb.
This is his foot, and this is foot X-ray. So I don't know if the spasticity result the deformity or other problem. So his problem is his right upper limb spasticity, and the result many painful spasms. So his problem is pain. His spasticity result in his pain, and his right hand will involuntary movement. Maybe resting treatment, but don't like. And he ever see the neurologist, but neurologists say not Parkinsonism. So this involuntary movement cause to be determinant. And his right lower limb also has a spasticity and a foot valgus deformity due to spasticity or not. He also poor balance and endurance due to spasticity. I ever inject 3 times Botox injection. First time in last June, about 100 units for right upper limb for reduce his pain. And second time is also inject 200 units for left upper limb and left crown toe. But the effect is main short, maybe one month. And the third time, about 1 month ago, I enjoyed the 100 unit for bicep, ECR, and EDC. Because the ECR and the EDC, he also have very painful. So I also inject the pectoralis major because he is self-paid. So I don't inject many dose.
So it's more for, okay.
Also, so patient expectation is decrease his neck and the upper limb muscle painful spasm, and he want to decrease the left hand involuntary movement and improve the right upper limb fine motor function and can ADL independent.
Before I forget, the young man that we saw before her, he's also on baclofen, right? Yeah, you may want to consider weaning off the baclofen and see if it will change his gait because he's got a lot of muscle weakness. And I think he's on 5 or 10 milligrams 3 times a day. Wean him off the baclofen, observe him, and see if he's more spastic or if he got stronger off baclofen. I'm not sure if the 30 milligrams will be enough to help him with the finger spasticity, but it may be causing weakness in his muscles. You did the injection about a month ago?
Yeah.
Okay. Okay, let's check if it's any better than before. Hello, ni hao. Yeah. That's the left one. The initial onset was in 1999.
Yes.
Okay, just relax. And this is the tremor that you're. Okay, just relax. Just bring it there. Is it there all the time?
Yes.
All the time. How about when she's sleeping?
Cold weather, sleeping, no.
They're not okay. This is very good.
One day good, one day no good.
Oh, okay. It changes from time to time.
Especially in cold weather.
Yeah.
Get worse.
Yeah, cold weather usually worsens muscle tone. Remind me, where did initially thalamic hemorrhage,
Yeah.
and then when she had the bleed again, what part of the brain did she have it?
Second hemorrhage over the sternum.
The thalamus again. Okay. Okay. What other medications is she taking right now? Baclofen. What else?
The anti-hypertension.
Antihypertension. Okay. Let's make this interactive. Anyone in the audience would like to come here and assess this lady with me? This is going to be an interesting examination. No brave soul? She doesn't have spasticity. This is primarily a movement disorder. She's got tremor. She's got very coarse tremor. And what I would inject the next time, I agree with the wrist extensors, but you also have to inject the wrist flexors. Remember, tremor is it's a biphasic event. It's the alternating contraction of the agonist and the antagonist. And what dose did you use? I don't think you will need a very high dose here. Even if you just inject 20 units to the ECR, 20 units to the ECU, 20 units to the FCR, 20 units to the FCU, you're not going to completely remove the tremor, but it will lessen. It will lessen that movement. Okay, just relax. Take a deep breath. I was hoping that when she relaxes that this will be more relaxed. It's not. She actually moved more. So that very movement sent more abnormal signals, causing this to get worse. She's got hyper...
No good.
Yeah, no, yeah, it's like this. Okay. Painful? Is it painful right now? Okay. Mm-hmm.
Okay. No, okay.
Yeah. So, okay, so I will recommend the 2 wrist extensors and 2 wrist flexors, 20 to 25 units apiece. And here, see the difference? When I was examining her, I thought the finger flexors were tight, but it's not. She goes into hyperextension. It's the lumbrical that I'm going to inject here. The lumbrical to the 2nd, 3rd, and 4th. This lumbrical, see, open, open, open. So if we can, it's not the finger flexor per se, it's the MCP flexor that I'm going to inject, the 3rd and the 4th. And then the 2 wrist extensors and 2 wrist flexors to treat the tremor. I was asking what part of the brain was affected. Curious to see if there's some extrapyramidal structures that are involved as well. What other medications did you take before? Did you ever take a drug called Haldol or Risperidol? The Xanax, okay. Yeah, it should not do that. Because I'm watching her, she goes like this too. So I'm not sure if she's got some oral dystonia as well. Okay, it's not normal too. Are you chewing anything right now? No, you're not. She hasn't. Have you noticed this? I noticed that she goes there. No, just relax. That, I wouldn't. Yeah, even when she was talking to me, she was going like this. Yeah. So she may have some dystonic and some oral dystonia as well.
Oral sensitive. He also ever told me oral sensitive.
Okay. And the oral sensitivity was because of? Okay. It might be more dental related. But I think we have a case here not of spasticity, but of dystonia. Definitely the hand dystonia, the tremor, and frequently, and many times movement disorders can coexist. So she has the dystonia of the fingers, and at the same time, she also has tremor of the wrist flexor and extensor. And did you see that? She goes, it's like she's chewing like this. So she may have some oral dystonia as well. Yeah. Yeah. So very low, again, low doses of Botox to those muscles that I recommended earlier. The lumbricals, put 5 units, 10 units maximum, and then 20 to 25 units to the extensor carpi radialis, extensor carpi ulnaris, flexor carpi radialis, flexor carpi ulnaris.
Has severe myofascial pain from neck to upper limb.
Okay. What is the standard of care here in Taiwan, in Taipei, for myofascial pain? Do you use the spray and stretch technique? Do you do needling, or just myofascial work? Is there a standard, or just whatever? Yeah. Yeah. The spray and stretch technique that Travell and Simmons popularized before is not commonly done anymore. We're doing more dry needling or sometimes low doses of Botox. That's what we're doing. I do Botox when I put the needle and I hear a lot of hyperactivity of the muscles at rest. Then I inject very low doses of very dilute preparations of Botox, maybe 2 to 3 units in each spot. Okay, just relax. Okay, just try. Can you try to relax and just let your hands fall asleep? Perfect. Even in this supposedly relaxed state, if you palpate the trapezius, this is more active. I mean, she's tightening up here as well. So is this a dystonic manifestation as well, perhaps? And perhaps that's the reason why she has this myofascial pain. Just look at the trapezius. See this? Okay, let's turn the wheelchair around so that we will turn you around, okay? So that we'll do the shoulder. And can you sit back?
Yeah.
Yeah, sit back. You can sit back. Yes. Okay, just relax. Can you see it? No, it won't be too. Let me bring you here. Okay, we'll come closer. We'll come closer to the camera. Is it possible to go like this if I bring her closer to you? Is it possible? No, it's not showing, but just it's just not there. Just relax. Oh, the pattern changed. I'm going to turn you around once again, okay? If you get dizzy, it's my fault. You see it? Tight. Never forget, the very first step of physical examination is inspection. You don't even have to touch her. And you can see the sustained contraction of the trapezius. Compare it to this one. Go to the other one. You see the line of the trapezius, but it's not as prominent as this one. Okay, so is she doing that? I think that's a dystonic component as well. Yeah. So I will inject the upper trapezius. Given her size, I'm going to inject anywhere from 60 to 75 units, and I will distribute it along the length of the trapezius. Here, 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 and here. Maybe 3 or 4 different sites. And again, I will use a concentrated form, 1 ml. We don't want it to spread too much. That might be the reason why. And then follow it with a lot of myofascial techniques. Okay, just look straight. Look straight. Look at the camera. You may want to inject some of the pectoralis muscle as well, and then maybe even the coracobrachialis muscle. She has a tendency to round her shoulder this way. Can you just relax? Just relax. Just relax. The more I tell her to relax, the more this trapezius is becoming more prominent. And if you and her, see, this one is more rounded this way, even though she's positioned almost symmetric. So I think she's going like this. The pectoralis and the coracobrachialis may be contracting as well. But I would, here, I would prioritize the trapezius and then the pectoralis major. Yeah. But I will increase the dose. You use 30 units of the pectoralis major, right? If we can increase it to around 50. I think it will be more effective. So 50, and then how much did I say? About 60 to 75. So that will be less than 200 units. I think that's what the problem. This is dystonia. This is not spasticity that we're dealing with. Is it related to the stroke? Most likely. So it's a secondary dystonia. We tend to think of dystonia as a primary phenomenon involving the extrapyramidal system, but in this case, I think it is related to her strokes. It's secondary dystonia. Make sure she's not on any medications as well that may be predisposing to this one. Prior exposure to anti-dopaminergic agents can predispose to some of the problems. It's usually, remember the movement in the mouth? I thought she may have some, but it's not really the one that we usually see in people with exposure to Haldol. Of course, now that she's on the camera, she's not going to do it. But what I was seeing earlier, see this depression here? She would go like that earlier when she was talking. Yeah. Can you tell me what is your full name? You see that? She goes like this. So she may have some oral dystonia as well. Do you see that? Yeah, what is your full name? Okay. Where in Australia did you live? Where in Australia did you live? Where? What city? Where? Oh, okay. Yeah. It's coming out. So as she's talking, you can see this. Okay. So you may or may not inject that. I don't think it's causing any problems right now. Only it becomes a problem will I consider that. Okay. Oh, her foot as well. Okay. Okay, I'm going to bring you back, okay? It's also the foot deformity. What's the problem, right? Did she have pain in her foot before? Did she have a lot of pain in her foot? Yeah, I know. The thalamus is involved. She's complaining of pain on the contralateral side, so we cannot rule out post-thalamic syndrome or central pain. Yeah. You all have seen people with spasticity. This does not happen. I mean, this is not spasticity that we're seeing. Again, this is a dystonic component. Did she, after her stroke, did she have a lot of pain on the foot? So that when you touch her like this, she's complaining of pain? Yeah. A spasm. Okay. Yeah, I was trying to rule out. Okay. I was trying to rule out the neuropathic pain related to the thalamic hemorrhage on that side. Surprisingly, the intrinsic muscles. Are you able to walk? Yeah. Okay. That's it. That's why. I mean, the intrinsic muscles of the foot are pretty much maintained. Yeah. Can you move your ankle this way? Okay. Just your ankle. Go back. Go. Move like this. Move like that. There. You just got very nice movement. I don't know the answer to your question. If this was predisposed by spasticity, I don't think this is spasticity. I think it's dystonia. She's got sustained contraction of the muscles here as well. And it's how long has this been like this since 1999 or only after the second stroke? 3 years. 2 years. Okay. Yeah. It's not the everter, but the muscles here are. I mean, there's a pull shortened here as well. Yeah, but it's not spasticity that's doing this. It's also a dystonic posturing of her foot that most likely has already led to some permanent contractures. It's hard for me to replace it to normal. I can move the ankle. There's no problem with the ankle movement, but the forefoot is already collapsed. If you feel the bones here, the just lost. Here, they just collapse. It's all flat like this. Injections won't help this. This is something that I will get a good physical therapist to do some manipulation and hopefully get her a good orthosis. Maybe not even an AFO, just a well-molded or well-casted foot orthosis will help prevent any worsening of that.
He's a 65 years old male. He suffered from right MCA infection due to he performed a right internal carotid artery stenosis post endarterectomy and then result MCA infection. So with the left hemiplegia since 2007. So now he also received the baclofen medication. So he locomotion most time under the scrotal assist, but he can use quadric cane for several steps. His problem list is his left upper limb and hand spasticity. So he used the antispastic spring. But his left knee is also stiffness and the ankle equinovarus. So his expectation is he can self-work for 10 minutes or ride a motorcycle. But now he used the scooter, so he want to ride a motorcycle.
Keep going. It's nice knee movement, some limitation, some limited knee extension, but it's fine. But in spite of wearing why did you choose an anterior, a posterior entry brace? Because it's not really supporting his ankle. He's still landing on his forefoot. Okay, we can have him sit down. But have him take his jacket off. Thank you. Has he ever been tried in a single point cane? Yeah, I'm just curious because our tendency with the especially with the wide-based quad cane, it's very stable. Whereas a single point cane, that's the only contact you have. But the tendency of many people is to lean that way. I think he's got enough, just the way he's sitting right now, the way he stood up, I think he's got decent trunk control. So if we can train him with a single point cane, less stable, I'm pretty sure it will force him to stand more upright. Plus it's less bulky than this. It's also, this one is heavy, and that's why a lot of people drag this. In the States, I'll see a lot of older women this small. They usually just walk this way anyway. So to consider a single point cane, I think it will help a lot with his truncal posture. Okay, let's do the arm first, and then we'll do the leg. Yeah, just a second. Have you done any injections before? No. Okay. Not so. It's only baclofen. It's only spasticity medication. Baclofen. Okay. Has the baclofen helped? No. If it's not helping, then either increase the dose or discontinue it. My preference is to discontinue it. I don't think it's going to help much in this case. Okay. Same thing. Shoulder. Did that hurt? I'm sorry. Did that hurt when I? Is it painful? It is? Okay, I'm sorry. How about now? Is this painful? Here. Where? Here or here? Oh, here. Okay, so not in the shoulder. Okay, so it's not an so no impingement sign. So tight thumb flexors, finger flexors, tight shoulder internal rotators, and adductors as well. But I don't know what the functional penalty of that is. So why don't we take your shoes and your socks off and your brace, and let's see you walk again. Okay. Can you move your foot up and down? No. Okay. No active movement. Very tight in the hamstring. Now this is the reverse of what we saw earlier. This is true spasticity. Watch this, okay? Slow. I'm able to bring him here. If I increase the speed of me stretching this, whoop, the catch is right there. True classic spasticity. Does he have spasticity of the knee extensors? No. And that would explain why he lacked knee extension during the terminal phase of stance. Tight in the ankle plantar flexor, again, spasticity. It was more tight when I moved it faster. By the way, when you're examining the ankle dorsiflexor, make sure that you are moving the ankle, not the forefoot. I see some people doing this examination don't. It's better to do it this way. By doing that, you're actually measuring the true ankle range. Plus, biomechanically, it's easier for you because you're going to use your entire arm to push it. It's less painful to the wrist. So this one has got true spasticity of the plantar flexors in addition to loss of range of motion because of the rheologic changes that I expect has happened in the muscle and in the tendon. Are you able to walk without your brace? Can we see you walk? Okay. Of course, it's not easy for him in a carpeted surface, but we'll see how. So all the more he should be using a straight cane. I mean, it will really put him in a better position. Toe flexors once again. No heel strike. And some equine varus. Okay. He's watching himself walk. Okay, you can turn around. Is he planning to self-pay for Botox? Or? Yes, okay. Okay. So what do y'all think was the primary problem here? I think gait is more problematic than the upper limb right now. The upper limb is not perfect, but I think we will be able to provide him with functional enhancements if we help him with his gait. Let's not worry about the motorcycle right now. I don't think we can reach that point. But if we want him to walk better, I would recommend injecting the following muscles: the toe flexors, the big toe flexor, the small toe flexors, the tibialis posterior, and the medial hamstring. I would inject the hamstring in this situation. I would use maybe 20 to 25 units to the big toe flexor, about 30 units to the rest of the toe flexors, about 40 to 50 units to the tibialis posterior. I will inject the gastrocnemius, 100 units. The gastrocnemius, unfortunately, is a very big muscle. But in order for you to maximize the effect, use a very dilute preparation, maybe a 20 units per ml dilution for the gastrocnemius, and spread it more on put 2/3 of the dose in the medial, which is larger than the lateral. Put the other third in the lateral gastrocnemius. Then if you have some left over, the medial hamstring can benefit from about 75 units to smoothen out the knee movement. Remember, the knee movement is one of the 6 determinants of gait. So if we want him to walk better, we need to correct that abnormality as well. I'm not even going to do the upper limb right now for practical reasons if he's going to self-pay, but if you'll be able to inject him with some more, I would inject the biceps and put him in a more relaxed position and train him. Can you do this? Just go up, down. Can you do that? No. Okay. So I was hoping that if we can relax this, we can put him in a better position and teach him some reciprocal arm swing. But that'll be my last priority. I think we will be able to help him improve his gait by just injecting the lower limb muscles, the hamstrings, gastrocnemius, the toe flexors, great toe and small toe, tibialis posterior. And this one, if you have some extra, maybe about 75 to 100 units to the biceps muscle. Fingers are tight, but he's open like this. It's not causing any problems with hygiene or with positioning. So maybe a nighttime splint. He has a splint, right? Yeah, so he can use the splint. I wouldn't worry about the shoulder, even though it's tight. If it's not causing problems with dressing or with cleaning, I won't waste my money there. I would concentrate. I think we're going to get the most investment. The best investment is injecting the lower limb muscles. And of course, after that, a lot of retraining. He's got pretty good control. His the core strength is pretty good. Just he sits better than I do. He's able to sit straight. I slouch. So I will focus more on stretching and strengthening the lower limbs. Yeah. And I will really consider using a straight cane. He's able to walk in a carpeted surface without this. This has a tendency for him to go like this. If it's a single point cane, it will help correct that position. He'll be more upright. Now, if he goes to crowded places, of course, this will be better, but otherwise, a single point cane will be helpful. And if you're going to continue with bracing, we may need to revise the brace that he has. Something that will provide better control in the ankle. Yeah. Yeah. Just watching him walk earlier when he was wearing this, the heel is not going to the ground. It's still in plantar flexion. And then turn around. See, it's not really supporting the ankle. Actually, I'm not sure what this brace is doing right now. If the intent for this is to deliver a posterior force as he's walking, it won't be enough. It's too short. In order for you have to extend the lever arm. So it will have to be a longer brace in order to deliver that posterior movement, if that was the intent. And even with a posterior ankle foot orthosis, I would recommend one that will go higher, just below the fibular head, to provide better support not only in the ankle, but also with the movement in the knee. Okay. Good. Thank you. 谢谢.
Thank you very much this morning to Professor Francisco. Is there any question or comments again? No? 那我们真的很谢谢大家今天在这个礼拜天的早上这么美好的礼拜天早上共聚一堂其实相信这么丰富的一个讨论跟学习那应该大家收获都很多那我们也这个代表学会谢谢这个艾利根公司提供这样的一个机会我们也再谢谢这个 Professor 这个 Francisco， 我们热烈掌声再谢谢他一次。Thank you very much. Thank you.